earlier about what we've been doing to study for while we're in quarantine. I've been going through Finoff and Harris, kind of outlining each chapter and putting together PowerPoints, and then supplementing that with the ACSM board review book. And so that's the PowerPoint for the ultrasound lecture that I'll be giving today. And another thing I've been doing, Dr. Mueller out in the University of Washington, I think he also has a channel where he's been posting videos for primary care sports medicine stuff. So how do I take control and share?
So the bottom middle, you should have a share screen button.
There it is. And all righty. Everybody see the screen okay? Maybe.
You're good, Jay. We can see it.
Okay, sweet. All right. So this is Sports Ultrasound Lecture. That's me. My name is Johnel Mayberry. I'm the Sports Medicine Fellow at UIC. I work along with Dr. Nicola and Dr. Skiba. And here's the outline for the PowerPoint. So we'll go through a little basics, some advantages and disadvantages of ultrasound. Then we'll look at these different structures, some normal and some pathology. Talk about a little bit of the evidence for MSK ultrasound and its use in interventions. So it wouldn't be ultrasound lecture without some physics. The way that ultrasound works, there's electric voltages, which is converted to sound waves by reverse piezoelectric effect. And those sound waves obviously require a medium to pass through. So we typically use an acoustic gel, but water can also be used as a medium. Then the sound waves are reflected at tissue borders and returned back to the ultrasound probe, which is then converts those volts via piezoelectric effect to be seen as a color on grayscale on the screen and produce an image. And just a couple of key concepts in ultrasound. We talk about acoustic impedance. It's just saying whether that ultrasound sound wave can pass through the actual tissue boundaries. So if you have something that has high impedance, you'll get a lot of reflection, and you pick up more signals on your screen. Whether something that has less impedance, which will go straight through. But more practically and more important concept is probably the angle of incidence, which is the angle at which the sound waves strike the tissue interface. You typically want to be perpendicular to the structure we want to look at, which maximizes the amount of echoes reflected back to the transducer, as opposed to oblique incidence, which some of those echoes may be reflected away from the transducer, which results in our effect, the anisotropy. And that's kind of depicted here in this diagram. Another key concept is volume averaging. I guess the best way to think about this is that all the equipment and structures that we're looking at are in 3D. And those sound waves need to be converted to a 2D image. So what happens is the processor would average some of those signals that come back into the sound wave, and some of those signals can be averaged above the baseline or averaged below the baseline. And if two signals are averaged above, they'll make a higher signal. Whether they're averaged away from each other will make a lower signal. And it's a key concept when you're actually looking at partial thickness tears and tendons. So when they say around 50% of the waves that come back need to be abnormal for you to actually pick up that abnormal signature from an actual tear or disruption in the tendon. So that's why it's important we actually look at a partial tear. We think there's a partial tear. We use those orthogonal views to actually to confirm that tear. And there's also key concept with volume averaging and needle visualization. I always was confused about why I couldn't see the needle and I saw all the other structures. I know I had to be in line with it. But if you're in the outer 25% of the sound waves, the volume would average the signal from the needle out, so it's going to be right up underneath it. Key concept. Talk a little bit about transducers. We talk about frequency. We know higher frequency leads to better resolution, but lower penetration. So there's an inverse relationship between frequency and amplitude. So it's good for imaging superficial structures with higher frequency transducer. Then our lower frequency transducer produce a lower resolution, but better penetration, obviously better for deeper structures. And we typically use a linear array, which those sound waves exit perpendicular to a flat transducer surface and minimize the artifact anisotropy. And is recommended for superficial structures in diagnostic imaging. But of course, the limitation is you have a smaller field of view. And with the curvilinear array, you have the sound waves exiting more of a fan shape from a curved transducer surface. Produces a larger field of view, but it increases your risk of anisotropy. And you typically use it for imaging deep structures or guiding procedures. And one key factor that we look at to determine or quantitative indicator for the quality of a transducer is the amount of emitting crystals. So when we go out to look for comparing transducers, probably a good question to ask, how many crystals do this transducer have? And those are different probes we use: our hockey puck, our linear array, and our curvilinear array. Talk a little bit about Doppler imaging. The two types, you have color Doppler versus power Doppler. In color Doppler, you signal both the presence and direction of flow within the structure. And typically blue means that flow is going away from you, and red is coming towards you. And power Doppler is very sensitive, but it actually works by picking up the reflection of red blood cells that's traveling within the area. And you see in this picture here, we have a patella tendon, which you see the color Doppler on the left, or the power Doppler on the right. And power Doppler is typically used as red and orange. And the more orange you have in that structure, the more orange signal, that means the more flow you have coming into it, more hyperemia, neovascularization, and possibly pathology. Some terminology, how we talk about the pictures that we actually see when we talk about ultrasound. So isoechoic, typically the same shade of gray as another structure. Hypoechoic is dark relative to the surrounding structures, less reflection. Hyperechoic is bright, light gray relative to the surrounding structures. And then anechoic is black and no reflection. And all these terms, probably except for anechoic, are relative to surrounding structures. Talk a little bit about artifacts now. We talked about anisotropy a little bit. It's a common artifact in MSK imaging. Occurs when the sound waves strike a structure at an oblique angle of incidence. The sound wave, as opposed to coming back to the transducer, kind of reflects away and leads to this artifactual hypoechoic anechoic appearance, which can lead to a risk of false positive, especially in tendon tears, where it has the most effects, more than ligaments and nerves. The next artifact is posterior acoustic shadowing. You have a hypoechoic anechoic region deep to high area of reflectivity or attenuation, commonly seen deep to bone or calcium. Also can be seen deep to scar tissue or normal fibrous septum. Then you have edge shadowing, which is a refraction artifact secondary to velocity change deep to a curve in the face, seen at the edges of tendons, torn tendons or normal A1 pulley. And then reverberation. You actually have multiple internal reflections from a highly reflective surface casting a dirty shadow below an object as opposed to a clean shadow, commonly seen with orthopedic hardware and needles. For needles to like is multiple needles deep and parallel to the original needle. And here's a picture showing those different artifacts. Here in the top left, you see the artifact of anisotropy, where you actually lose your biceps tendon in the bicipital groove. And then here in the supraspinatus tendon, you have a calcification with the posterior acoustic shadowing. And in the bottom left, you have a cystic lesion, and you see the edge shadowing. Another concept, you can actually see this pass-through volume enhancement. So things that's deep to cystic lesions will actually show up brighter compared to surrounding structures. and then reverberation here in the needle on the bottom right. And it actually shows that you have the needle directly over the actual, directly underneath the probe. Some advantages and disadvantages of ultrasound. Of course, it's portable point of care imaging, direct dynamic visualization of a injured structure, can aid in the pathoanatomic diagnosis, relatively inexpensive, and side-to-side comparisons are easy to obtain. No risk associated with contrast, ionizing radiation, and actually for peripheral nerves is actually the superior image modality. Some disadvantages: significant time, effort, and cost investment to become proficient. A lot of people, even after their training, seek out ultrasound courses, which can be pretty expensive. Ultrasound, you can rule in a fracture, but you cannot rule out or characterize a fracture. There's also the fact that you cannot really adequately look at intra-articular pathology or labral pathology on ultrasound as well. And then it's always a big one that gets you, even if you do see a surgical lesion, most surgeons will still get a MRI to justify surgery, pre-surgery planning, or just as a reference for surgery. So you probably end up doing double the work. Now moving into the meat of the lecture, I guess, taking a look at these different structures and how we describe them. So we talk about a tendon, which is probably the thing we evaluate the most with ultrasound. Typically imaged best with a high frequency linear array probe. Of course, except for deep structures, people with large body habitus, you might have to use a curvilinear array, such as iliopsoas or gluteals. The normal sonographic appearance is a hyperechoic, tightly packed linear echoes in a fibrillar pattern on long axis, and then a stipple cluster dots and a broom end appearance on short axis. And here's a picture depicting that there. As far as pathology, we talk about tendinosis, it's thickening, swelling, hypoechogenicity, and heterogeneity with loss of the usual fibrillar echotexture. And you may also see calcifications, some intraperitendinous hyperemia on power or color Doppler, indicating some neovascularization. And here's a picture of Achilles tendon. You see the loss of the fibrillar pattern, swelling, and the hyperemia, indicating tendinosis. And then as far as tears go, so a partial thickness tear would be a well-defined focal defect. It's confirmed in two planes like we talked about earlier. Often occurs at critical zones of specific tendons. A full thickness tear, the tear extends from the deep to the superficial surface, but may not involve the full width of the tendon. And then a complete full thickness tear and full width tear or retraction of torn tendon fibers may appear as a gap in the tendon or a complete absence of tendon. And that's kind of shown here. Or you have this peritendinous edema or swelling, loss of the actual fibrillar appearance, and you see the retraction of the two torn tendon ends. Some more pathology: calcific tendinopathy, usually a calcium hydroxyapatite deposition within the tendon. The appearance is hyperechoic with variable amounts of posterior acoustic shadowing. And symptoms typically related to mass effect or impingement or an inflammatory response in the resorptive phase, but may also be asymptomatic. And we can see that in this picture here. You see this hyperechoic signal with the posterior acoustic shadowing representing calcium deposition. Some pearls and pitfalls of tendon ultrasound: anisotropy, which can mimic tendinosis or tear. It's a common finding in MSK ultrasound, especially when evaluating the rotator cuff. Edge shadowing could be useful in identifying torn tendon ends. And of course, dynamic imaging is really helpful when you're looking at superficial tears. And then there's some clinical significance, controversy about the clinical significance of neovascularization, even though we use it a lot to indicate whether there's some actual pathology. So moving on to muscle, the normal sonographic appearance is hypoechoic. Muscle fibers and fascicles were hyperechoic septa or periepimysium forming a pendant pattern on long axis. And they talk about this Van Gogh Starry Night pattern in short axis. And we can see that here, kind of that pennate pattern on the left and long axis. Short axis, you see the epimysium, perimysium around the actual muscle fibrils, and the septae running between. So as far as pathology goes, you see focal disruption of normal fiber structure, may appreciate a focal deficit. You see hemorrhage, which can lead to hematoma and scar formation. And of course, strains are more common in muscles that cross two joints. Contusions are typically seen and involve the deep fibers next to bone. And then this myositis ossificans. When you have a muscle tear, it can be a calcium deposition within the injured muscle. And that's actually seen early on ultrasound and x-ray. And we can see that here, this calcium deposition, irregular hypochoric structure with this posterior acoustic shadowing. Moving on to ligament. So long axis is the most useful in imaging ligaments. Of course, the first thing we do is identify the bony landmarks and then align our transducer in long axis to the ligament. The normal sonographic appearance, you have this hyperechoic fibrillar pattern, less compact than the tendon. May appear as a hypoechoic structure depending on the surrounding tissues, and it's less susceptible to anisotropy than actual tendons. The grading of pathology is similar to that on physical exam. When patients have pain or your grade 1, you have swollen and hypoechoic without fiber disruption or laxity on dynamic testing. Grade 2 or partial tear, you have evidence of fiber disruption, may have some laxity, but an appreciable endpoint. And then grade 3 is a complete tear when dynamic stress imaging demonstrates laxity without any bridging endpoints. And here we have a ATFL. On the right is the normal structure. On the left, you have this intertendinous tear, partial tear with a calcification. And you can see the loss of your normal fibrillar pattern that you expect to see with a tendon. Or ligament, sorry. Next up is nerve. Of course, the best way to image a nerve is in short axis. That's how we track it back even through the arm. High frequency transducer allows for more detailed evaluation. The normal sonographic appearance is hypoechoic nerve fascicles and hyperechoic intra-extraneural epineurium. You have this honeycomb appearance in short axis and the fascicular appearance on long. Pretty minimal anisotropy, and it's typically adjacent to vessels. In pathology, you'll see swelling and hypoechogenicity, often with loss of the normal fascicular pattern. May demonstrate focal swelling proximal to the entrapment site or focal narrowing, not sign at the entrapment site. Dynamic testing may demonstrate subluxation or dislocation, especially when you're evaluating like the ulnar nerve at the cubital tunnel or the fibular nerve. And here's what that looks like on ultrasound. So your normal on the left, that normal honeycomb appearance, and then on the right, you see the nerve is swollen and loss of that honeycomb appearance. Moving on to bone. So evaluation is limited to superficial bone because it has a high impedance. The normal sonographic appearance, smooth, linear, and hyperechoic. The pathology you can't see a fracture where you see disruption of the smooth cortical surface, some periosteal thickening, and a stress injury. Hypoechoic hematoma at the fracture site, and hyperemia is common, as well as you have pain on sonal palpation. In a stress fracture or stress reaction, you can't see that periosteal thickening with a reduced cortical discontinuity. And here we see the left tibia, normal, thin line, hyperechoic signal with the periosteum attached directly to the bone. On the left, you'll see there's a disruption in the actual bone itself, the hyperechoic, and the periosteal thickening with some edema within the periosteum, indicating a stress reaction / fracture. Cartilage, the normal sonographic appearance, typically hyaline cartilage is hypoechoic or anechoic, non-compressible and compared to like a fluid collection with a uniform thickness. Fibrocartilage can be hyperechoic or mixed echogenicity with uniform echo texture. There's salt and pepper appearance. And pathology is typically have a limited evaluation of cartilage due to its intra-articular location. But you can see a loss of uniformity in hyaline cartilage or focal hypoechoic defect in fibrocartilage. But looking for secondary signs may be more helpful, like a perimeniscal cyst or joint effusion. And here's a good picture of kind of the normal structures, and you see the cartilage adjacent to the bone and deep to the tendon, nice and smooth. Moving on to vessels. So the normal sonographic appearance of vessels, of course, is the hypoechoic and endoechoic tubular structures. Arteries are pulsatile, thicker wall, less compressible. Veins are thinner walled, easily compressible, and non-pulsatile. Pathology often requires formal vascular studies outside of typical ultrasound, but a focal enlargement can indicate an aneurysm. And if a vessel is non-compressible, it may indicate a thromboembolism. And here's a picture just of an artery and a vein. And the vein is compressible compared to the artery. So moving on to the evidence for MSK ultrasound. So in 2009, Sibin Company studied whether ultrasound-guided injections affected clinical outcomes and intra-articular injections. It was randomized to 148 painful joints. And sonographic guidance resulted in 43% reduction in procedural pain, which that makes sense. You're not hitting cartilage or bone. 58% reduction in absolute pain scores, 75% reduction in significant pain scores, and then 62% reduction in non-responder rate, which, you know, that can have some placebo effect. You know, the more of a show we put on, the more it seems like the patients actually are helped. But the second one, the last one, would say sonography also increased the detection of infusion by 200% and volume aspirated by 337%. You just can't beat actually seeing an infusion and being able to drain it. In 2004, Laredo and Company also demonstrated that ultrasound-guided injections in the subacromial space resulted in improved pain and shoulder function assessment scores at 6 weeks versus landmark-guided injections. And then in 2004, Tiffany and Company looked at the detection of rotator cuff tears in ultrasound versus MRI and concluded that ultrasound and MRI had comparable accuracy for identifying and measuring the size of full thickness and partial thickness tears and rotator cuff. But of course, that may be dependent on the actual sonographer. So interventional sports ultrasound. So for injections, ultrasound-guided injections are more accurate than landmark-guided injections, and that sort evidence rating is an A. And like we said previously, it may be site and practitioner specific. Then ultrasound guidance injections are more efficacious than landmark guided injections. That sort rating is a B. And it's because the studies limitations, lack specific targets and diagnosis. Like the previous study just said painful joints, whether that was the shoulder or the elbow or the knee or hip, didn't specify. And most of the studies actually use steroids, which steroids can seep into different areas and cause pain relief. But it does have potential to reduce complications because you know exactly where you're going. And of course, it's important to use ultrasound guidance when you're doing diagnostic injections, but you know exactly what you're injecting. Then it says ultrasound guidance injections are more costly than landmark guided injections, which has a sort rating B. It's just a small number of studies. And as far as advanced procedures, when doing tenotomies, I haven't seen a faster release for chronic exertional compartment syndrome or carpal tunnel release. But I know some people out there doing those with ultrasound. Of course, you need ultrasound to do that compared to doing it blind. Trigger finger release or nerve hydrodissections and regenerative medicine techniques. You're spending that much money out of pocket. You want to know exactly where you're putting the medicine. And then it says ultrasound also has the potential to augment, improve, or replace current surgical techniques that we talked about for carpal tunnel release. And I think that's it, short and sweet. Any questions? Anybody still listening?
We are.
Jay.
Thanks, Jay. Really good.
Absolute
I'll stop
pleasure.
recording.